Mary, let me ask you quickly. What are your thoughts? Do you have any data on delivery systems? So, in addition to like a sub Q sent to house, what about IV versus there's even patch delivery forms? And there's also some brands out there that we know do a liposomal glutathione. So, what are your thoughts on
Yeah,
the different
yeah,
delivery
there are
forms?
I've talked to our, I forget his name, Dr. Patel. He's a pharmacist, fellow pharmacist colleague.
Yep.
Well,
Yep.
I love him, and it increases NAD. I just, I don't like the smell. It's quite pricey, honestly. Sorry about that. Anybody that uses them, and I haven't. I can't see my patients doing a pump every day. Do you know what I mean? Like, but they'll inject every day. Does that make sense? So for me, it's about compliance, and they're not going to spray. Maybe a patch they'll put on if it's once or twice a week. You can do it in adjunct, but I'm always thinking about compliance.
Right.
And most often, yes, it burns, but they feel a difference, and it's great for recovery as well. A lot of our bodybuilders do like that also. It's not the only way, but for cholesterol, and that's like antiquated now. Like nowadays, with everyone, what is it, 1 in 5 people now on a GLP, it's rare that you're having someone come in for hypercholesterolemia, right? It's something that we just treat, but we are seeing, a reduction in LDL, significant reduction in LDL when you do glutathione for 4 months. You have to be
Good.
consistent with it. So in terms of delivery systems, I would say the liposomal is okay. I do use it once in a while in the morning. I just don't have a lot of data with how that, and it goes into the plasma. So I would say it would work pretty well. I don't know if you do, if you wanted to chime in on that one.
I actually don't necessarily have the data. I mean, we do have a fantastic masterclass and interview with Dr. Patel,
Okay.
and just not necessarily about his product, right? But just about the molecule as a whole.
Yeah.
So if you're a newer member here, if you have not watched that replay, you really want to go deep into glutathione. I mean, it is one of the master molecules for a reason. And, when we really look at the effects from not just antioxidant, but when we look at what's happening in the liver, and Mary, you just alluded to it. We always talk about upstream first. So
Okay.
before we go to add the BHRT, before we go to do a GLP or any advanced peptide therapy, there's so much that can happen upstream and so much has to filter through that liver, y'all. Like so, and that's where a lot of hormone conversion happens. Like it happens there. That's where we are detoxing. That's where we are converting from fat soluble to water soluble. Like what are we able to handle in our body? And so I do believe that there's just a really beautiful opportunity as clinicians to appreciate liver first. And I really thank you for saying that and just helping to kind of call that out tonight. All right, we got a couple of really amazing cases still left to cover before we wrap up tonight. We're going to see what we can do in 10 more minutes. I have a new client, 57-year-old male, who was diagnosed with MS 3 years ago. Other than a stable lesion on the spine, there have been no changes or symptoms. He's been stable with no active flares. He gets Ocrevus infusions 2 times a year with his neurologist. Are there any peptides you would recommend for support? Maybe thymosin alpha 1 or any peptides that I should avoid?
That's a tricky one. With autoimmune, you have to be very careful with probably LL37 is what I would avoid. Definitely, I think TA1 would be fine. PC would also be fine if he's only, but I wouldn't do it close to the time that he's having his dosage. If he's only having it twice a year, I'd probably wait a good 30 days before initiating any peptides while it's still at its peak. The half-life is pretty long on that if it's just twice a year. And I would go low, go slow with his. I would start, I like, BPC. I think that would be okay. Depends on what you're treating. If he's not having any flares, there's really no need to start on anything. You kind of want to keep it there. Always put him on low dose naltrexone. I know I go low. I don't go up to 4.5. I probably stay at 1.5 to like maybe 3 milligrams max, depending on how he responds. But every single one of my MS patients or autoimmune are on low dose naltrexone and a low dose, and they just do maybe twice or 3 times a week of TA1. Less is always more in autoimmune patients or really anyone. We really just need to sensitize the receptors. The end of the day, it's really, it's about the receptors. So I hope that answers. Yeah, peptides I would avoid are definitely tesamorelin, definitely CJC. You can get anaphylaxis with CJC, NAD, 100% avoid. Anyone that doesn't check endotoxins, NAD sometimes can cause, I don't know if you guys have, it's not a peptide, but I would definitely avoid that peptide. I would just stay clean. Make sure you're getting 503A. So I would say TA1, and just avoid LL37, anything that's going to affect the immune system or maybe trigger an autoimmune response. And then just make sure you're putting them on low dose naltrexone. Start on probably 0.5 milligrams and then go up to maybe 3. Usually I start at 0.5 for about 7 days, then I go up to 1 for 7 days if no response, and then they're going to sleep so much better. So hopefully that helps. DA1 alternating.
Love that, Mary. Thank you. And I'm going to also add into that, Trisha, always think upstream. So in that, like, for what reason? We're always asking, what are the outcomes? So Mary just said, what are we treating? Based on our licensure, the type of practitioner, some of you are not treating anything, right? So, but what are the outcomes that we're looking to support or produce in this client or patient? And so I always come to think of, remember, and you guys, we are bringing out new education for you. So don't feel like you've missed something. So I'm just going to always give you context. First and foremost, what are the inputs coming into the system? So what's driving the system? How did we get here to begin with? It's great that they're stable. That's fantastic that there's been no progression. So that's really good. And so what are the current inputs? How do we get there to begin with, right? What's that internal terrain? So oftentimes when we think autoimmune, it's, I'll never forget this. One of my mentors really highlighted this forever ago. If we think of autoimmune, body attacking self, self-attacking self. And while this is a deep question, not everybody resonates with it because autoimmune has become so normalized, but really and truly, why is one part of me trying to attack or kill another part of me? Like, really, right? So if we get deep into the subconscious, emotional, I'm not asking you guys to do psychological work, but it is a very interesting place to look from. So all of a sudden, when things stabilize versus in autoimmunity, there's often flares. What flares the system? What's jacking up that system? What's overloading that system? So oftentimes when we are working with clients and patients that are autoimmune based, we're always defaulting to make sure that foundation is strong, because it's really, if we think about this, instead of that we're treating autoimmune, and what I love when we have the longevity conversation, when we look through the lens of longevity, longevity isn't about treating, it's how do we slow the rate and pace of biological aging. And so when we look through that lens, we start to have this conversation around resilience. Autoimmunity has lost resilience. So how do we bounce back? How do we take a hit? How do we hit the mat and get back up? Autoimmune has a flare, the whole system crashes. And that's why we're always taking biologics to try to keep it at a suboptimal so nothing stresses it enough that it crashes even worse. But what if we could build the floor, right? What if we can raise the base so that they become more adaptive, more responsive, hence concepts around hormesis and things like that. So there's foundational stuff, but I'm going to always push back and challenge you guys. Please don't default to just a molecule. Let's get even more intelligent in our approach as clinicians to appreciate what are the inputs coming in before we just default to a molecule. What, if anything, needs to be reduced and removed? Because it's what are the environments that they keep going back into? What keeps triggering and spurring that system to break down, or stabilize? Because in stabilization, allopathic care, we've been taught to stabilize and treat and manage a problem state. But what longevity and regenerative medicine is all about is we're not trying to manage a broken down state. We are looking to say, let's actually stabilize and repair and support that natural ability to create enhanced capacity, resilience, rejuvenation, regeneration. So if we stabilize, how do we get stronger? How do we get more resilient? And those are the things I would ask you to look at. And that's not always in a molecule. Mm-hmm. Now that's an autonomic nervous system. Maybe it's a pidolon, right? Maybe we need to stabilize that pineal gland. How are they sleeping? What are some of the HRV structures? What's happening with nervous system, vagal tone? So this now expands our toolbox in addition to just a molecule. Okay. And this is how we create practices that are reoccurring revenue models, because it's not just about a one-to-one and a one product. Don't sell peptides, sell programs, sell outcomes, sell models where there's resilience and healing long-term. Thank you for letting me have my soapbox. I apologize. This is a really good question. And Dr. Joe, if he's still on, might want to chime in on this one too.
Yeah.
I have a 46-year-old male with low testosterone, mid 500s, previously on TRT. but was told to stop, what? Because of a newly diagnosed HPPEF. Sorry, I don't know that. HPPEF. What is that?
Is it heart
Is it
failure with preserved ejection fraction?
okay with severe with severe LVH? Is there a contraindication to Wolverine protocol as an alternative to testosterone? That's not an alternative to testosterone, but go ahead, Mary, you take that.
Testosterone is contraindicated in heart failure. I mean, that's a simple answer. Is that what you're asking?
Yes. Yeah, but he was also asking if there's a contraindication to taking Wolverine blend protocol as an alternative to testosterone.
I'm sorry, I missed that. Do you have a question to me?
Yeah, we are deferring to you, Dr. Joe. Give us a little insight. So it looks like they were on TRT. There is a heart condition, right? So new diagnosis, and so now they're off to bring in the Wolverine protocol as an alternative.
Wolverine protocol. Well, can somebody describe that for me? Identify
Yeah,
what we're
Wolverine's
talking
going to be BPC.
I mean, we're talking about
500.
BPC.
I don't know why this person is thinking about that versus testosterone.
Right. Right. There are two different therapies. You know, somebody has a low ejection fraction. We have FDA approved SS31 for cardiomyopathy. That would be the first thing I would do with a peptide. And I would do, you know, you guys were talking about low dose the other day. I didn't really agree with that, like 5 milligrams of SS31. I'm very high dose in SS31 in patients, especially if they have low EFs and we're trying to restore myocardium and myocardiocyte function. You know, TB4 plus SS31, I've seen some pretty dramatic results and responses. So, and no, I would not place them on testosterone at this time. It can put them in heart failure.
Yeah, she was told to stop, and I agree. SS31 for sure, high dose, maybe 50 milligrams 3 times weekly. But as an alternative to testosterone, Joe, can you chime in a little bit on that supplement Epic that you like?
I'm sorry?
The Epic supplement, EPIC.
Oh, that's a redesign of fenugreek. So it works in about 50% of patients to increase testosterone, but you're not actually giving them testosterone.
Right, and that might be a good alternative.
Yeah, I don't honestly. I think that's a medical liability issue. If you have somebody in low ejection fraction, we really want to avoid raising testosterone. I don't know what the current level of the testosterone is in this patient or the symptoms. So I need more information to understand why I would want to increase this person's testosterone and how they would benefit.
Right. Dr. Joe, can you take a minute and reiterate? So when we're looking at heart, right, we're looking at a heart failure. I mean, the role of like a TB 500, or you said specifically TB4. Can you speak to that for a moment? Because there is definitely use case indicators in the research that would, so not necessarily the Wolverine stack, but if we parse out that molecule in addition with SS31, what are your thoughts on that?
You broke up the molecule. What are you referring to? I'm sorry.
So TB.
Yeah. You know, both of them synergistically will restore at least in animal studies. They've done it in mammal studies that both of them are very effective in restoring damaged myocardium, and increasing the genesis of the growth of myocardium in the heart. It's actually pretty remarkable. I'm sitting here at a table right now at a business meeting, and one of the people at the table, we treated his dad in 2018. He had an ejection fraction of 15, and we treated him with we'll call it Wolverine brand. We get BPC 157, SS31, TB4, and in a matter of several months, they were going to put him into hospice and die. His ejection fraction went to 45, another 2 years. So is that a one-off? I presented that case at A4M in 2019, and I still get inquiries today online saying, hey, I got kidney issues and heart issues. I come see you as a patient. I said, no, I don't really treat that. You have to be very cautious, but you know, we have to do the right thing and get the word that our experience out there among our colleagues that these things are risk-benefit ratios every time we make a decision to treat a patient. And when somebody has an EF of 15, what is their mortality? Huge. So what do we have? I'm sorry, I hate to put it this way. What do we have to lose? And we won on this one. I mean, his EF was 45, and he was just showing this colleague next to him, his dad, It was actually his dad. He was working out on a bicycle with a big smile on his face, and lived another 2 years. So we just need so many clinical trials to prove the things we know anecdotally that we see in our our lives every day, in our professional lives. But that is the, honestly, for lack of a better description, that's the stack I would use. I would avoid testosterone. I don't know ejection fraction, but there's a good chance you can actually improve cardiac function in these patients. Thank God we have studies on SS31 now that prove we can improve myocardial health and function. So that's where would I go? I would go with that one.
Thank you so much for that. I'm so glad you were able to offer that up. And hopefully you guys are realizing, like, this is what's so exciting about peptide therapy. These molecules, and this is also what's important about conversations like this. So even as we give you protocol and guidelines, there's a range. It's a up to, right? So when we think of, not everything is, like Dr. Joe said, not everything is a low dose. Like there are use cases where we need to really come in a really strong way to support that system. And this is where, gang, I'm going to just keep encouraging you as clinicians, please stop following influencers. There are so many people out there talking all the blends and the trendy stuff because that's what people are buying. And then when your patients come in or they're spending money and they're not having the right results, this is why the industry is being cleaned up. This is why you need to go back, do the certification, watch those modules. Even in the TB4 discussion, we talk about that in the certification. We talk about these clinical use cases, the studies, where this is showing up, how to be thinking about this. So when you have a complex case, I'm going to once again, please advise you, don't think about doing a blend, even the Wolverine stack, like do individual molecules. We want to separate. We want to be intelligent in what we're looking at and why. And remember, there's always upstream data. So the last thing I'm going to chime in, and even kind of coming back to the testosterone part of this conversation, when we look at the big sex hormones, whether it's man, woman, whether it's testosterone, estrogens, when we especially look at those sex hormones and that depletion, you always want to go upstream first, especially if we cannot replace that main hormone. So what drives testosterone? What drives estrogen? Well, once we go through menopause or andropause, okay, we're not pulling from the testes and the ovaries to the same degree, but we're still pulling from the adrenals, right? Like when you understand, like look at those pathways, where it's coming from, and what does that mean? Well, what's their stress response? What's happening with their glucose? What's happening with their insulin? What's happening with those metabolic pathways? And so what upstream strategies can we safely put in place? And that doesn't always have to be a molecule, depending on the severity. What can happen with those inputs? What can happen with stress? What can happen with sleep? What can happen with food? What can happen with drink? What can happen with breathing, oxygen saturation? Like there's simple things that can modulate those glucose, right? All those mTOR overactivation pathways that can further suppress, inhibit testosterone production, estrogen, you know what I mean? So I'm always going to tell you guys, think upstream. Inputs right before terrain. Like you just because you might not be able to do the molecule, but you can save their life with something as simple as, can we get them stopping to be a mouth breather? Like, you know what I mean? Like that won't pop them up 20 times a night. Put some tape on their darn mouth so that they can sleep through the night. All right, listen, gang, we are, let's see. Mary, we've got another. Do you want to take one more? Or are you done?
We have time.
I mean, we're at it. This is another complex. Dr. Miklos, of course, you waited till the end. There you go, sir. 41-year-old had an MI rounding in the ICU, a member of our group. Ooh, heart function normal. Had a lesion on his LAD that was reperfused. Okay, Dr. Miklos, come on.
Okay. I'm sorry.
You give it. Doctor to doctor. Emergency room, give us really quickly, and this is our last one, gang. These are great questions that didn't get answered. We'll move them to next call, or we'll start to put answers in the group. This has been amazing. Dr. Miklos, let's bring you on and round it up.
So this is a hospitalist in our internal medicine group, otherwise completely healthy. A guy had a remote history of family history of cardiovascular disease, had an MI while rounding in the ICU, sent him to the cath lab. He had a lesion in his LAD that was reperfused, and he's doing very well now, other than the fact that his EGFR is now in the low 40s. And so just curious about thoughts on targeted peptide therapy to maximally support his renal function during this time.
There's a good study with clotho and improving renal function, but I wouldn't go straight for that. Right now, I'd probably start with cordyceps sinensis and Solidago. I don't know if you're familiar with that, but cordyceps is one of those molecules that I know it's not a peptide right now, but you don't have to start with peptides. Cordyceps has been shown to help with, and Solidago too, with GFR and even increasing VO2 max by about 10%. It's actually used in Tibet. They found it on top of caterpillar. And I like Pharmanex blend. They were able to extract that molecule, 5 parts of that molecule of the cordyceps sinensis that were responsible for kidney health. Cordyceps sinensis. So Pharmanex has a product called Vitality. I really like that product. I put my dad on that. He had also some renal